Hi everybody, this is Dr. Douglas Stoddard and this is the Semi-Minute. It's been a few months since we last spoke, and in the past few months I've noticed an increase in patients coming in to see me due to pain from osteoarthritis. So I thought it'd be a good topic to discuss today because it's pretty common. In Canada, about 37% of people have osteoarthritis. If you break it down by age group, about 16% of people aged 29 to 49 have osteoarthritis, 40% of people aged 50 to 64, and 45% of people over the age of 65 have osteoarthritis somewhere in their body. So it's pretty common. And I think the surge in people coming in to see me in the past few months is due to one of two reasons. They're either less active than they used to be, that is pre-COVID, and osteoarthritic joints often respond to more activity, or the exact opposite. They're more active than they used to be, and because of that there's more load and use of these arthritic joints, and therefore they can hurt. So it can be one explanation in some, another explanation in others, but suffice it to say we're seeing more complaints due to arthritic joints. Now, we used to say osteoarthritis was the wear and tear form of arthritis. In other words, loads placed through the joints on a daily basis somehow degenerates the joint. And what degenerates primarily is joint cartilage, which is the rubbery shock absorber in the joint. So over time, the joint cartilage thins or wears, and it can tear. So we say wear and tear. However, we now know that it's much more complex than that. It's not just load through the joint, crushing the cartilage in some way that makes it thin or tear. There seems to be a metabolic component to this problem as well, which basically means that the metabolism in the joint cartilage is altered, thus making it weaker. The going theory now is metabolism is altered by something that we call insulin resistance. Now, insulin resistance is part of a problem we call metabolic syndrome, and lots of people have this. Metabolic syndrome is the combination of high blood pressure, diabetes, high cholesterol, and obesity. So this is a common set of problems in the Canadian population, and it all seems to come back to this concept we call insulin resistance, meaning our bodies are not sensitive enough to the hormone insulin. Now, why may that be? One of the links in many people, not everybody, but many people, are high carbohydrate diets. And of course, we have for years advised our Canadian population to eat a high carbohydrate, modest protein, low fat diet. Now, for some people that's fine, but there are some people that respond negatively to this type of diet, and in some people it can contribute to insulin resistance and therefore predispose you to osteoarthritis. It's certainly something we're thinking about as we try and understand more about the metabolic abnormalities of osteoarthritis. Getting back to the problem in terms of Canada, as I said, 37% overall of adults in Canada suffer from this problem. There are two very common ways that we treat osteoarthritis. The first is using anti-inflammatory medications, and these are medications specifically targeting inflammation in the osteoarthritic joint. We used to tell people there was no inflammation in osteoarthritis, but we now know that's not true. So anti-inflammatories in some people can be very helpful, controlling pain, making life a little more enjoyable, and of course that's all very important. The problem with anti-inflammatories is it is among the top few classes of drugs that put people into hospitals on an annual basis. And these numbers are quite pronounced, where about 10,000 patients a year in Canada are hospitalized due to complications from anti-inflammatories, the most common being stomach ulcers and stomach bleeding, or intestinal ulcers and intestinal bleeding. And unfortunately, out of all those people, about 1,500 of them die every year. So 1,500 people of the 10,000 admitted to hospitals actually die from anti-inflammatory related complications. This is a big deal. And so what we try and advise patients is that if you're on anti-inflammatories, take drug holidays. What that means is that you may be on the anti-inflammatory for 5 to 7 to 14 days at the most, and then you take a week off to let things heal in your stomach and intestine if they were starting to go the wrong way. Now, the other common method of treating osteoarthritis is usually reserved for end-stage arthritic joints, meaning we can't do anything else about them, and we replace those joints. There are about 140,000 joint replacement surgeries done in Canada annually at a cost of $1.4 billion. This is approximately $10,000 per joint replacement. Now, unfortunately, not all those joint replacements go well. About 80% of patients are happy after joint replacement. 10% feel that there hasn't been any change in their pain, and 10% feel worse. So 80% of people are happy, 20% are not happy after joint replacement surgery. And because of that, we really need to keep reserving joint replacement surgery as a last resort. And if it's a last resort, then that means you've tried everything you want to or care to try, and then you don't have much choice. You need to go and get this procedure done. And again, good news, 80% are happy, but the bad news is 20% are not. So what are some of the other things that we can do to help with osteoarthritic pain? I divide treatment for osteoarthritis into 3 levels. Level 1, 2, and 3. Level 1 is the least invasive. It includes therapy, which helps strengthen and make more flexible muscle groups around the arthritic joint, thus helping control discomfort coming from the joint. So therapy, orthotic prescription in select individuals. By repositioning the foot in the shoe, we can help weight-bearing joints, which includes the hip, the knee, and the ankle. Bracing can be used on select joints, again, to help control force and therefore give some relief to the joint. And medications. We already talked about anti-inflammatories. Another common medication to help control the pain of osteoarthritis is plain old Tylenol, the drug name for which is acetaminophen, which has less side effects and a better side effect profile than anti-inflammatories. All those are level 1, non-invasive, very simple, and effective for many people. Now notice in level 1, we haven't really done much to the arthritis. We're really working around the arthritic problem. Level 2 interventions include injections. Now we're going into the joint. We're being more aggressive, more invasive. Because we're going into the joint, we have a 1 in 10,000 risk of infection. 1 in 10,000 is not a reason to reconsider an injection. It's just too low to worry about, but it is a risk you have to understand. Now, what we inject is cortisone. Personally, I'm not a big fan of it. I don't use it myself, but many doctors still offer it. Cortisone has been implicated in furthering the degenerative process, and that's something, of course, that we're trying to avoid, so it's not my favorite thing to do unless we know the person's joint is beyond repair in any other way. They're scheduled for joint replacement surgery, and we may just be desperate to try and give them some relief. Maybe in those situations, I'll suggest cortisone. Second injection is called a visco supplement. This is a gel that we inject into the joint. It seems to provide relief in about 50% of people for about 6 to 12 months. The third category of injections are the regenerative injections. These are platelet-rich plasma injections, and in Canada, that's it. And other derivatives of blood also, are currently on the market, but they're all derivatives of blood. We used to do stem cells injections, but in Canada we can't do those at this present time, though many other countries are still offering these injections. So that's the injection level. 1 in 10,000 risk of infection, otherwise very safe. And make sure your injections are ultrasound guided, because unfortunately 30% of injections done by physicians can be missed. We actually put it in the wrong place, believe it or not. And we can get around this problem by using image guidance for our injections. Third option is what I mentioned earlier, joint replacement surgery. This is level 3, meaning this needs to wait to be a very last resort. So, in conclusion, osteoarthritis, very common in Canada, very common in Canadians. Lots of hardship in many people, possibly related, even likely related to insulin resistance and metabolic syndrome, something that we can do something about. And then level 1, 2, 3 interventions, level 1 conservative, level 2 injections, a little more aggressive, level 3 joint replacement surgery always needs to be a last resort. Thanks very much. This is Dr. Douglas Stoddard with the Semi Minute.